This part and this section is where you're going to build upon that lit review a whole lot, but in a different way, really. You're not just sort of looking to narrow down a question, but you're looking for answers, illuminations of how you proceed forward. You're going to learn a lot of things about such things as hypothesis, operationalizing variables, how do you get a sample, how do you recruit people, how do you do an IRB, and they're all things that you can glean from your lit review. So for instance, if you've looked at interventions that have worked to improve an issue or to help community health, then you would say, you want to measure that with a different population, you would say, if I do such intervention, I will see a reduction in adolescent diabetes by 5%. And that's your hypothesis. If this, then that. And you've said specifically what you're going to get. But again, you've taken that jumping off point from your lit review. Another thing to keep in mind is in the literature that you looked at, how did they operationalize the variables? So how did they operationalize an intervention? Did they look at specific programs? Were these programs validated? Were they used within certain populations? Did they use pre and post test surveys, or have they used surveys to glean ideas, answers, responses? Those should be validated. This is not the point, and never, if you don't have to, should you be creating something out of whole cloth. There are lots of validated surveys. Many of you have talked about them in your lit review. These are the kinds of things you want to use, these tools to measure the impact of a program or an intervention or the impact of a prevention. Whatever you choose to do, those are the tools that you would use. They would be validated. They've used in other studies. You could then adapt them and use them in your study. You're not recreating the wheel. You're building, again, like we talked about in the very beginning, on the shoulders of other people. The second part is that sort of we really need to be mindful of, and you get it later, but you need to be mindful of it in the beginning, is how did that sample, how is it recruited, and who's in that sample? And you're going to hear me say time and time again, less than 50 is really iffy because the statistic is very difficult. If out of 50 people, only 10% improved in a program or an intervention or had the impact you wanted, then that's a very small number of people to look at. Why were they different than the rest of the population? So you want to get as many subjects as you can. This is one of the reasons why some people use secondary data, because it's already collected and it's already a big group of people, so it's easier to use. It's probably de-identified, so you don't have to worry about confidentiality and those kinds of issues. The problem is you have to go with what they measured. So you have to really look at that secondary data that you think you might want to use and see what's there before you sort of see if you're going to use it. However, one of the things to keep in mind too is that some people who are teachers want to use their students as subjects. There's some problems with that. Number one, you already have some power over them, so their ability to consent freely, to drop out of the study, to not take part, might be suspect. So you really need to think about that when you're doing students, because yes, you can get classes and classes of people or co-workers, but again, if you are their boss or if you work with them or if you have any input in them, a little bit of coercion could be there. So those are things you need to think about. Also, what is your subject population? Are they protected class of people? Are they prisoners? Are they people in the military? Are they patients? None of these people, patients specifically, if you're looking at them and asking them questions, they come for healthcare. They don't come to be part of a study, and sometimes it's very difficult for them to understand that they don't have to take part in the study to still get that healthcare. Certainly, if you want to look at patient records and glean information from there, then you should have gotten a HIPAA waiver, and if you don't, then you have to get that HIPAA waiver post hoc through the IRB. But again, a lot of these things you should have seen in your lit reviews that you've done. How did they measure things? What were their hypotheses? What worked and what didn't work? How did they recruit people? What were their outcomes? How did they deal with people not responding in the post-test, if that's what you want to do? So these are things you need to keep in mind, some questions that a lot of you actually have alluded to in issues in the lit review. And those are sort of, look what they've done. You can do better. You can build upon it. You can not make the same mistakes. You can expand a population. But you really do need to be mindful of all of this stuff because it does impact your study. Be mindful of how you're going to get those access to those subjects. If you're not going to use secondary data, what environment are you going to get access to them in? Sometimes when we do students or we do people that we treat, we have somebody else administer the survey. And a lot of my research, there are research fellows that administer the survey and no one ever sees me because they might confuse their care with myself. They also might want to please me as opposed to answer correctly. And that's why we train research fellows to sort of do a pre-test, a post-test, or look at interventions or outcomes. That sort of makes it 2 or 3 steps removed. And then because these people are not treating them, there's no confusion. Still get a HIPAA waiver, still get all of these kinds of things. But these are some of the questions and some of the things that you really need to keep in mind. In using students, one of the problems that we've seen, and it's been a big issue in psychology, is using your own students to do a survey or using them as a sample population. Unless it's part of the normal educational process, then this is something extra. Some people have tried to do extra credit. The problem is if someone opts out, they should also have access to some kind of extra credit. Should be related to what they're studying or doing in the classroom. You can also have people administer it and not you, and you decode it and there's no names attached to it, sort of through SurveyMonkey, those kinds of things. But the students have to be very much aware that it doesn't impact their grade, that the grades are turned in before they say the post or pre-test kind of questions. So it gets very tricky very fast, and you might want to reach out to me if you think that these are the kinds of issues you're going to have. Always reach out to me, ask me questions. I'm here to help, but sort of try to be thinking ahead, not sort of as a just in time when we reach a topic, because the topics go very fast, but they're all connected together. And from the lit reviews that I've seen, I think you guys have a really good steady base. But again, this is all new territory. So please reach out to myself, your advisors. We're all working as a team to help you progress forward and do the best that you can do and improve patient care and patient outcomes.